first we will go for the GDM diagnosis. If the certain high risk factors are present, then we will go for DIPSI in the first ANC visit. Otherwise, if the no high risk factors are present, then we will repeat the OGTT at 24 to 28 weeks of gestation. If it comes out a positive, then we will go for the medical nutrition therapy for 2 weeks. Then after 2 weeks, we will assess the fasting blood sugar level and the postprandial blood sugar level. If the fasting blood sugar level is less than 90 mg per deciliter and postprandial blood sugar after 2 hours is less than 120, we will continue the medical nutrition therapy. But if the fasting blood sugar comes out more than 90 mg per deciliter and postprandial 2-hour blood sugar is 120 mg per deciliter or more than, then start the insulin as required to manage the elevated blood sugar level. We will adjust the insulin and frequent follow-up, 2 weekly follow-up, and we will go for the fasting blood sugar and 2-hour postprandial blood sugar. Now, if the patient blood sugar is controlled and properly managed, then we will plan for during labor and delivery. We will plan whether we have to add the insulin or not. If the patient is throughout the pregnancy, patient is on MNT, then no need of adding the insulin during the labor. But if the patient is on insulin and blood sugar is not controlled, then during labor we have to add the insulin to avoid the hyperglycemia. Now the certain pharmacological treatments are available. The first and most important is the lifestyle modification is the most important for other than the other hyperglycemic measure. Insulin is the first line agent recommended for the treatment of GDM. Insulin has the safest because it doesn't cross the placenta. Metformin we can add after 20 weeks of gestation, and glyburide may be other drugs for choice. Not recommended as the treatment. Now the insulin management, if we require after giving the 2 weeks of MNT, if we need insulin, then we can add the different types of insulin are available in the market: rapid acting, short acting, intermediate and long acting, and depends on the fasting and postprandial blood sugar level. We will add rapid acting and long acting, and combination we can also get. So if the fasting blood sugar is more than 110 mg per deciliter, during interpartum we should give IV insulin infusion with early glucose monitoring. And those women who require insulin less than 20 units over 24 hours prior to the labor may not need interpartum use of insulin infusion. Only the plain RL drip is sufficient. So insulin doses stop after the birth, and capillary blood sugar monitoring we will go for frequent monitoring for 24 to 48 hours. So what are our goals to control the glycemic index? The management of blood glucose level play an essential role in reducing the risk of complications that may occur during pregnancy. So to reduce the risk of adverse pregnancy outcome, early diagnosis and stringent maternal blood sugar control is very essential. So our goal of HbA1c should be less than 6%, equal to 6% to be achieved without significant hypoglycemia. So the fasting blood sugar should be level as a less than or equal to 90 mg per deciliter, 1 hour postprandial less than or equal to 140 mg per deciliter, and 2 hour postprandial blood sugar is less than or equal to 120 mg per deciliter. This should be the strictly followed. The women with GDM need to monitor their blood glucose level at least 4 times a day, fasting and 1 or 2 hours after each meal. So the target range in GDM, the goal in pregnancy is the safety increase time in the range as quickly as possible. Early diagnosis is the best for the maternal and a fetal outcome, while reducing glycemic variability and time of range. Continuous glucose monitoring, when used in addition to self-monitoring of blood glucose, can help to monitor the glycemic range closely. So how we can monitor during antenatal visit? We can monitor because we have to consider both maternal and fetal risk factors as well as the fetal growth. we have to rule out certain abnormal fetal growth, maybe a macrosomia or a growth restriction, presence of polyhydramnios, hypertension in pregnancy, proteinuria, other OBS complication. Fetal heart sound is heard at each ANC visit and treat accordingly. So, for monitoring during antenatal period, ultrasonography plays a major role for detecting any fetal abnormality. So, thrice with minimum gap at least 3 weeks. The first at 18 to 20 weeks of fetal anatomical survey, that is a T5 scan, target image fetal focal anomaly is the best part to rule out any anomaly. Sometimes the blood sugar patient may be a type 2 diabetic mellitus and it may get neglected. So at 18 to 20 weeks we can detect any anomaly. And the second is a growth scan at 28 to 30 weeks of gestation. And next growth scan at 34 to 36 weeks of gestation to detect the fetal weight, polyhydramnios, placenta, location. So USG fetal biometry and amniotic fluid estimation play a role in high risk pregnancy outcome we can also. So additional 4 ANC visit along with the 4 routine visit is required in high risk pregnancy until delivery and during 6 week postpartum up to 6 week postpartum. So the question is when to deliver. If the patient is controlled on diet, on continuous medical nutrition therapy, then we can continue the pregnancy equal to or more than 39 weeks of gestation. Then expected management can be done up to 40 weeks 6 days in appropriate with antepartum testing. Well control on a medication, deliver at 39 weeks 0 days to 39 weeks 6 days. But if the poorly controlled, so expert guidance support earlier delivery but data lacking regarding the precise timing. So we can deliver the 37 weeks to 38 weeks 6 days may be justified. But if we are detecting any abnormality, if the poor glycemic control, abnormal fetal testing, then we can terminate in between 34 to 36 weeks 6 days. So if the estimated fetal weight is more than 4.5 kg, counsel the patient regarding the risk and benefit of the scheduled cesarean section. Because in the normal delivery, the chances of shoulder dystocia is high. So we will counsel the patient regarding the outcome, normal delivery outcome, and counsel regarding the cesarean section. Now, what are the immediate newborn care is required in patient of GDM? Evaluate for the immediate hypoglycemia. The chances of hypoglycemia is very high in the patient of GDM in newborn. If the blood sugar level is less than 45 mg per deciliter within first hour of birth and at 4-hour interval using the glucometer till 4 stable reading, glucose values should be achieved more than 45 mg per deciliter. So exclusive breastfeeding is promoted preferably by direct breastfeeding. If hypoglycemia persists less than 20 mg per deciliter, infant should be referred to a higher center with the facility of the proper NICU with 10% dextrose IV infusion drip 100 ml per kg per day where pediatrician is available. So other chances of risk are to the newborn is respiratory distress, convulsion and hyperbilirubinemia. Now what are the postpartum care required in patient of GDM? The medical nutrition therapy. All pregnant women with GDM should get medical nutrition therapy as soon as diagnosis is made. Medical nutrition therapy for GDM primarily involve a carbohydrate control balance meal plan which promotes. So that leads to optimal nutrition for maternal as well as a fetal health, adequate energy for appropriate gestation weight gain, achievement and maintenance of normal glycemia to reduce the risk for obesity or diabetes to both the mother and the offspring. So the guideline for gestation weight gain, it is regarding according to the BMI. If the BMI is less than 18.5, the recommended range of total weight gain is 12.5 to 18 kg and if the BMI is in between 18.5 to 24.9, the weight gain should be in between 11.5 to 16 kg. If BMI is between 2.25 to 29.9, the average weight gain should be a 7 to 11.5 kg, and if BMI is more than 30, the weight gain should be only in between 5 to 9 kg. So the optimum growth and development of the fetus, keeping in mind prevention of postprandial hyperglycemia and excessive weight gain in the mother. So proper vigilance is required. As per the Indian Council of Medical Research, the National Institute of Nutrition 2020 guideline, the first trimester no increase in the calorie intake in patient of the GDM, and in the second and third trimester an additional 350 kilocalorie per day is required. But for the twin pregnancy, in the second and third trimester, the extra calorie 700 kilocalorie per day to support the rise in energy expenditure and gestational weight gain for twin pregnancy. Now the energy for obese women. So it is very important for the caloric restriction. Calorie restriction of 30 to 33% or calorie intake in between 1600 to 1800 kilocalorie per day is advisable to help control weight gain and glucose level in obese women without leading to ketosis. But caloric restriction less than 1500 calorie per day or a 50% restriction is not recommended. Ketosis associated with a lower mental or motor function in the offspring and hence should be avoided. Now for the pre-pregnancy, BMI is also very important to calculate the caloric requirement during pregnancy. Now the carbohydrate for the GDM patient, the carbohydrate intake is the biggest challenge because it causes the greatest impact on the post-meal blood glucose level. The post-meal blood glucose concentration depends on the amount of intake, type of the carbohydrate, digestion and the absorption. So most guidelines recommend carbohydrate intake of 33 to 45% of the total energy distributed over 3 main meals and 2 to 4 snacks per day. So RDA for carbohydrate gram per day is 175. Now glycemic index. Glycemic index ranking of food based on how it affects our basal blood sugar level. So low glycemic index less than 55, medium GI is in between 55 to 89 and high glycemic index is more than 70. So the factor affecting the glycemic index depends on the effect of processing, intake of type of starch, degree of ripeness, type of sugar, additional of fat, protein, fiber and acidity. So the low glycemic index versus high glycemic index, in cases of the GDM you have to prefer the low glycemic index food because they suppress the hunger pangs and control the postprandial glucose excursion, improve the pregnancy outcome in GDM. So how to reduce the glycemic index means we can add the dal in rice or a rajma rice. So different type of mix higher glycemic index food with the low glycemic index and then we can reduce the postprandial blood sugar level. So we can calculate the glycemic load before with the help of the dietitian. We can advise the patient as a diet chart and glycemic load can be calculated by the carbohydrate content into glycemic index divided by 100. So now the carbohydrate. We know the carbohydrate of simple and the complex type of carbohydrate. The simple carbohydrate absorbs rapidly and raise blood sugar level. So we have to prefer the complex carbohydrate which can absorb delayed and the releases blood and the level of the blood sugar is not high. So most important is splitting meal at the breakfast. We can advise the patient of the GDM that she can split the breakfast. First she can take at 8 a.m. and after 2 hours she can also take the another meal. 10 to 20% carbohydrate of total calorie at breakfast divided into 2 meals and taken 2 hours apart. So the second meal effect, the ability of whole grain and legume intake at a single meal to influence the postprandial glycemia at the next meal. Eating whole grain or legumes at breakfast decreases the postprandial glycemia at lunch and or a dinner on the same day. Eating whole grain or legume at a dinner reduces the glycemia at breakfast the following morning. So the second meal effect has an important implication for the day-long control of blood sugar and ultimately long-term glucose tolerance. So the certain dietary fibers are also very important because it improves the satiety, stabilizing the blood sugar level and prevent the constipation, which is a major complaint during the pregnancy. So recommendation of fiber intake is 25 to 40 gram per day. The sources of various sources of fibers are available in the market: soluble fiber, insoluble fiber, soluble like vegetables, fruits, beans, lentils and legumes, oats, barley, flaxseed, chia seeds, and insoluble fiber like millet, brown rice, legumes, tomato, cucumber, nuts and various fruits. So the protein during pregnancy, protein also play an important role in the synthesis of placental, maternal and fetal tissue, and therefore its requirement increases. The effect of protein consumption on blood glucose level is it flattens the glycemic response of food that helps to control the postprandial glucose spikes, and so its intake is recommended with every meal. So 20% of total calorie intake should be from the protein only. The RDA for protein for the second trimester is 9.5 plus minus 9.5 gram per day, and the third is a plus 22 gram per day. So the protein rich food sources are curd, yogurt, paneer, nuts, eggs, soya bean, chicken, pulses, sprouts and the fish. So modify the recipe of traditional Indian food. Whole pulses are a good source of protein and a fiber, and thus blunting the post-meal blood glucose spikes. So in spite of taking the wheat chapati, we can make the chapati with the help of the wheat and the besan. So it is a moderate carbohydrate, contain protein as well as a fiber. So better postprandial blood glucose level and low glycemic index. Protein supplementation helps in decreases the postprandial blood glucose level and improve the antioxidant enzymes. Malonaldehyde, HOMRA index also improve, stress hormones are reduces and decreases the in plasma 2 or insulin level increases. So this shows that supplementation with the protein help to improve the postprandial glycemic control by alleviating stress disorder and oxidative stress injury in women with GDM. So food order of the meal in women with GDM, managing postprandial blood glucose level is challenge. Food order has a significant impact on postprandial blood glucose level. Like a fiber, for the fiber, she can intake the salad. For protein, curd, meal, various carbohydrates that leads to a lower postprandial blood glucose level. So the consuming protein and the fiber first, followed by the carbohydrate or starch, the post-meal blood glucose spikes are lower. This is a very important. Hence, consumption of protein and fiber first followed by the carbohydrate is called as the correct food order in diabetes management. First fiber, protein and then carbohydrate. According to the ICMR NIN 2020 guidelines,